Hello, everyone, and welcome to today's webinar, The Role of the Laboratory in Managing Thyroid Health. I am Marie Stone of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. This webinar is educational and thus offers free continuing education credits. Please click on the Continuing Education Credits window at the bottom of your screen to obtain your credits. I'd like to now welcome our speaker. Having received training at Singapore General Hospital for Internal Medicine, Dr. Tar-Choon Aw has garnered tremendous research and experience related to laboratory medicine and endocrinology, including that of thyroid health and disease management. In addition to publishing over 160 professional articles, Dr. Aw has received the Inspiring Mentor Award and has given over 340 lectures around the globe. Dr. Aw will now begin the presentation.
Good morning, good afternoon, good evening, everyone who's joining us today from wherever you are. I thank you for joining us for this session on thyroid testing and the role of thyrotrophin receptor antibodies. I want to thank Abbott for arranging this webinar. Let me tell you what I will do today. After the short introduction, I will let you in on the lesser known facts about thyroid function tests, which are critical for practicing laboratorians and clinicians. Then I'll move into TSH receptor antibodies, the types and measurement, its role in diagnosis, as well as its role in treatment, and with some concluding remarks. Well, the repertoire of thyroid tests we have includes the thyroid hormones, TSH, free T4 and free T3, which has largely replaced total hormones. We have the antibodies, right? TRAP, TPO antibodies, and thyroglobulin antibodies, and also ability to measure serum thyroglobulin for patients with thyroid cancer monitoring. In the assessment, we use the thyroid test for diagnosis, monitoring treatment. There's some caveats when we test inpatients, and increasingly the case is to screen pregnant women for thyroid dysfunction. A little revision on thyroid physiology. Hypothalamic factors release TRH or TSH releasing hormone acting on the pituitary to stimulate production of TSH, and TSH acts on the thyroid to produce T4 and a little bit of T3. Right? What is often forgotten is that 80% of the T3 comes from the further metabolism of T4 outside of the thyroid. And then thereafter, there's target tissues upon which the thyroid hormones act, and its effects are manifest with feedback regulation. Critical in understanding thyroid testing is the TSH-free T4 relationship. Since the introduction of third-generation TSH assays, at that time, it was shown that a twofold change in free T4 concentrations would be accompanied by a 150-fold change in the TSH signal. Thus, the signal for TSH is so much greater than that for free T4, such that for minor degrees of thyroid dysfunction, you are going to see a more reflection in a change in TSH. We have recently re-evaluated the TSH-free T4 relationship at this year's AACC meeting, and using the Abbott Architect assay, right? We show that in this assay today, a twofold change in free T4 from 14 to 28 picomoles per liter is accompanied by a 350-fold change in the TSH signal. Because of this superiority of TSH, right, most laboratories will do a TSH first testing algorithm or a TSH plus free T4, such that if it is high or low TSH, we go down the appropriate pathways to either primary hypothyroidism, primary hyperthyroidism, and then when both are normal with a change in the TSH, there's this entity called subclinical hypo or hyperthyroidism. And then when the TSH is high and the free T4 is also high, then we have to consider some more unusual causes such as assay interferences, a pituitary secreting TSH tumor, or thyroid hormone resistance. And equally, when we have a low TSH and a low free T4, then pituitary tumor or previous pituitary surgery or radiotherapy has to be considered. When we derive reference ranges for thyroid hormones, we have to remember the possible interfering factors that could affect the values for our reference population. And you will see that many of the interfering factors include drugs that the patients may be taking. So good history of drug consumption or treatment is particularly important for all the parameters that we have. And it is well known that from top to bottom, right, we have got many drugs that can affect the TSH as well as T4. One of them that is particularly interesting is amiodarone, which is a great anti-arrhythmic drug. The reason is because amiodarone has two iodines in its structure, such that because of its long half-life, right, the iodine gets deposited in the body, and the effects of amiodarone in patients, up to maybe about 10 or 20% of patients may suffer amiodarone-related thyroid dysfunction. And we may be called upon to try and assess whether it is a type 1 or type 2 thyroid dysfunction, right? Type 1 is in patients that have latent or some nodular disease, right? And the iodine in the amiodarone adds fuel to the fire and increases the symptoms. Equally, on the other side, we have another type where the iodine suppresses or even is toxic to the thyroid tissue. And the management and outcomes are quite different. In fact, the type 1 induced thyroid dysfunction is more difficult to treat compared to the type 2. Let me come back to reference ranges in TSH. This document from the NACD guidelines is often forgotten, right? It's a good close to 20 years now, where the expert committee recommended that we should take at least 120 rigorously screened normal euthyroid volunteers with no history or family history of thyroid dysfunction, no visible or palpable goiter, no medications, and most importantly, no thyroid autoantibodies, all right, measured by a sensitive immunoassay. Right? Frequently, most laboratories either adopt the manufacturer's cutoff values or verify with a smaller set. But in reality, right, if we use very strict criteria of no thyroid antibodies, then you're going to find that the reference ranges are tighter. Right, and this is what we found in a study in Malaysia in a community health fair. We find that the range of values in women was 0.3 to 4.4, and in men was 0.3 to 4. And if we take the middle 97.5, right, after log transmission, right, this is what you see. And so you have much tighter values of upper limit of about 3. The lower limit is still about 0.4, 0.5. Another thing to be cognizant of is that, yes, as one gets older, right, the TSH tends to go even higher. And this is data from the US National Health Survey, the NHANES, where they show that, yes, there is an effect, but it's more so in the very old 80 plus, where the TSH would be much higher, that the 75th, 97.5 centile is 7.5 in the 80 plus, whereas up to 70, it's still about 4.3. Another thing is the ground is shifted. Previously, we used to think that subclinical thyroid dysfunction will always inevitably lead to overt thyroid dysfunction. And in the last several years now, there's increasing trend towards not treating and observing patients with subclinical hyper and hypothyroidism. And this is very well summarized in this review in Lancet Endocrinology 2 years ago. For instance, in older patients and also those that have TSH less than 7, right, subclinical hypothyroidism, right, the inclination is to observe. Equally, in subclinical hyperthyroidism, right, if the patients are also older or at the lower range of the free T4 and free T3, they tend to hold off on any immediate treatment. And the reason for this is that if we look at the natural history of untreated hyperthyroidism, right, there are effects of time. At 2 years follow-up, right, 17% of subclinical hyperthyroidism in the range of 0.1 to 0.4 would normalize. By 5 years, it goes to 32%, and at 7 years, up to a third of them would normalize. Also, if we look at the initial TSH values in patients over 60, right, at 1 year follow-up, those with 0.05 to 0.5, 3/4 of them normalize. And of those with TSH less than 0.05, 13% will normalize. And of all patients with low TSH, right, close to 60% normalize. So again, underscoring that for subclinical hyperthyroidism, right, there's virtue in waiting and staying your hand and observing. If we look at patients with subclinical hypothyroidism, you find that most of those patients are actually a little over-treated, right? So you find the green bars are those that remain subclinical hyperthyroid, 14% to 26% remain subclinical hypothyroid. But if you look at the purple bars, right, they become subclinically hyperthyroid from overtreatment ranging from 13 to 27%. And in the blue sector, you'll find that anywhere from 1 to 10% are hyperthyroid, right? Suggesting that a lot of the hypothyroids are iatrogenic in origin and should not be overly treated. Another thing to remember is testing of patients who are sick, especially when they are hospitalized, because they are more likely to be sick euthyroids and where the body responds to the illness rather than a true thyroid dysfunction. In fact, the T3 often declines, and when they recover, it normalizes. This is due to a shift in the metabolism from T3 to reverse T3. Equally, there could be a diminution in TSH with a slight elevation in the free T4, but the total T4 declines as well. So best to avoid treating or investigating patients in hospital, but if so, keep this in mind that they could be sick euthyroids rather than true thyroid dysfunction. Let me shift gears now to thyroid autoantibodies. As you know, there are at least 3 important thyroid antibodies we measure: the TSH receptor antibodies, antibodies directed against TPO, and antibodies against thyroglobulin. Right? In autoimmune thyroid disease, like Hashimoto's thyroiditis, right, almost over 90 or even 100%, right, have TPO antibodies. Equally, with improvements in assays, right, patients with Graves' disease, over 80 to 90% have got TSH receptor antibodies, right? So the TSH receptor antibodies are of a few sorts, right? The most common is the inhibition of TSH binding by the immunoglobulins. So we measure the inhibition of labeled TSH binding to recombinant TSH receptor by antibodies present in the serum. When the field first started, right, there was interest in trying to measure the stimulating antibodies which is evidenced by the production of cyclic AMP in thyroid cell lines that have been transfected with the TSH receptor. But this is kind of laborious and only available in research laboratories. And then from the congenital hypothyroid screen, it began to be realized that some of the children with what appeared to be TSH receptor antibodies with hypothyroid profiles were actually because these antibodies, instead of being stimulatory, are actually blocking. But for the most part, most of the TSH receptor antibodies are stimulatory, and so the assays that measure the inhibition of TSH binding is kind of like a total antibody measure. So the TSH receptor antibodies have got both stimulating antibodies, a small amount of blocking antibodies, as well as some neutral antibodies. To complicate matters, sometimes in the evolution of disease, all right, there could be a change in the proportion of these antibodies. Notwithstanding it, the vast majority are all probably stimulatory. That can be measured and good correlation with the TBII assays. So the utility of the TSH receptor antibodies, because they modulate the thyroid follicular cell function, they may be involved in the pathogenesis of Graves' ophthalmopathy, and possibly also in osteoporosis. Because these TSH receptor antibodies are IgGs, they can cross the placenta during pregnancy and may be involved in fetal thyroid dysfunction. Right? The greater value would be as a measure of autoimmune hypothyroidism, right, where the diagnosis of Graves' disease is difficult, or in Graves' ophthalmopathy, especially in unilateral eye swelling. And the main utility today is in also the prediction of neonatal thyrotoxicosis, as well as in amiodarone-induced hyperthyroidism. So the bioassays, because it's less available, more expensive, and more tedious, right, have largely been replaced by the TBII assays, which are automated and using chemiluminescence and other non-isotopic assays. So the bioassays have given way to the competitive immunoassays, and there's also now a TSI, the stimulatory immunoglobulins, which is automated as well from Imulite. So the indications for TSH receptor antibodies are mainly in diagnosis, right? For Graves' hyperthyroidism, patients with ophthalmopathy, right? Especially unilateral, and sometimes in this rare condition where they have got skin involvement and one is not sure what it is, all right? So presence of TSH receptor antibodies would be helpful. And in the fetus and neonatal period, all right, especially in mothers with Graves' disease, right, the likelihood of neonatal thyrotoxicosis should be considered when the TSH receptor antibodies are positive in mummy. A big change today is the chance of remission of hyperthyroidism, right? A high baseline TRAB on diagnosis would mean that remission is unlikely, and the treatment may need to be longer, right? Usually, hyperthyroid patients are treated with antithyroid drugs for 18 months, and then after that we stop and observe to see whether they relapse or not. On average, about 50% of patients relapse. And so increasingly, the use of the TSH receptor antibodies at diagnosis, at a year or at 18 months to monitor whether or not to continue antithyroid drugs. So for diagnosis today, if a patient has got clear-cut signs of hyperthyroidism, we don't need the TSH receptor antibodies. However, if the features are less obvious, TSH receptor antibodies would help, besides also providing a baseline indicator for prognosis. The assays have greatly improved such that the sensitivity of the TSH receptor antibody for Graves' disease with the new third generation assays are better than 95%. And the specificity has also improved. Right? I just want to show you this that came out a few years ago, where the Immulite assay for the stimulation antibodies was introduced. And this is looking at the correlation with the previous radioreceptor assays. And you find that there is clearly, a good distinction between Graves' disease and other thyroid disorders like autoimmune thyroid disease, non-toxic goiter, and normals, as well as multinodular goiters. So quite a good separation. And then another group also confirmed that the assay with this Immulite assay was also quite good. All right, and you can see this ROC curve to diagnose Graves' disease, all right, at 0.57 units of TRAB had a sensitivity of 98% and a specificity close to 100%. So the performance of TSH receptor antibody assays continue to demonstrate good performance. All right, this is a recent paper from last year, all right, looking at two third generation assays, the Crypto and the Roche assays, all right, very good correlation, good precision, less than 10%, and with cutoffs, or even in healthy volunteers, right, 90% of them had a TRAB that was below the limit of detection, or the LOD. And you can see that the precision is quite good in both these assays. And more studies, right? This is another recent paper this year comparing the Crypto with the Immulite and the Maglumi. And this is Bland-Allman plots to show that the results were very close. So again, another paper this year that comparing the Immulite and the Roche the ROC for diagnosis of Graves' disease, 0.4 on the Emulite, all right, which is a stimulatory assay, and 2.7 on the Roche, right? So the positive rate was fairly similar using cutoffs supplied by the manufacturer or derived from the ROC analysis. Okay, all right, we're done with Graves, diagnosis of Graves' hyperthyroidism. Right, let's move to orbital Graves. Right, this is Graves' orbitopathy or Graves' ophthalmopathy. Right, very obvious sort of starey look. Right, and this is after the patient has had some surgery. Now, when patients are treated, right, they improve, and if they have either no ophthalmopathy or mild symptoms, right, after they respond, right, more of them have improvement in the ophthalmopathy. Another recent paper looking at serial TSH receptor antibodies, right? It can help to inform the timing of intervention, right, in the thyroid eye disease. Right? If the TRAB levels are increasing, then the treating doctors may be persuaded to do some intervention. The studies on its use as a predictor of eye disease is increasing, showing good correlation between the initial TRAB levels and clinical activity scores. One of the things that's known is that smokers with orbital Graves have worse outcomes, and this is evidenced by how the decline in the TSH receptor antibodies was delayed by over a year in those who continue to smoke. And even also when patients are treated, right, generally the TSH receptor antibodies decline. So it can also be used in its monitoring and to aid decision making. This is a recent paper on the use of the stimulating antibodies, the TSI, on the Emulite. However, the ROC curve was only 0.6, right? Little underwhelming. But part of the reason is because we now know that besides the TSH receptor in the immunopathogenesis of ophthalmic Graves, there's also an IGF-1 receptor that's involved, and the pathogenesis of ophthalmic Graves' disease is a bit more complicated than what we used to believe, that all of it was mediated by the TSH receptor antibodies. However, an interesting new treatment has come out of this TRABs, right? There's a blocker for TRABs, right? An antibody blocker, right? So this is a patient, right, on the upper panel, and then after treatment, you can see there is improvement, right? This is without surgery. Right? What they did was to give this drug K170, right? This is still just published online in Thyroid, right? So you see on this side here, the patient's serum TSAB declining, right? And they were given intramuscular doses of K170 over several weeks intervals. So this is something that we need to keep an eye on. Okay, to assist in diagnosis, another one is, this is a very unusual skin change in patients with Graves, right? Especially in the early stages, we would not know what it is, and if they have got TSH receptor antibodies present, then we can be more confident that this is Graves' dermopathy rather than something else. So we have covered hyperthyroidism as well as orbital and skin changes of Graves helping in the diagnosis. Right now, I want to talk a little bit about the fetal and neonatal thyrotoxicosis. Right, in pregnancy, women with Graves' disease with the maternal TRABs, they can cross the placenta and cause fetal as well as neonatal thyrotoxicosis. This diagnosis is not so easily made, right? Because you know, all babies have a rapid heart rate, they are a bit stressed, they cry. So it is often missed and only diagnosed late. But if mummies have a high TRAB, then the doctor should consider this and maybe evaluate the TRAB and thyroid function in the child. But it's only a rare occurrence, right? We're not sure why this happens, right? Some genetics, some environmental factors. The level at which this occurs may be around 5 units on the Brahms assay. The correlation between the binding assay, TSH binding inhibitory assay of the Roche, as well as the stimulating antibodies of the Siemens, there seem to be about equal in this regard. Also, there's TRAB that I mentioned earlier that was found in patients with congenital hypothyroidism, all right? And when they looked further into this, right, the few cases showed that the TRABs there were not stimulatory, right, but were blocking to cause hypothyroidism. So whether or not this may be useful for diagnosis in this congenital hypothyroid screening scenario will await further larger studies. Right. So the next area I want to talk about is in the treatment, which is the best use of the TSH receptor antibodies, which is what is the likelihood of remission and how does it guide the treatment. In treatment of Graves' disease, we can use antithyroid drugs, we can use radioactive iodine, or we can go for surgery, but the drugs remain the preferred modality, right? Because it's easy to administer, right? The comorbidities are less. Plus, there's also some information about the kinetics of TSH receptor antibodies that influence the decision. You see that over the years, right, the use of drugs is increasing in the US, right? This is a study that was reported in Thyroid a few years ago, right? The diamonds, right? The squares is radioiodine. Radioiodine is coming down, and surgery has kind of remained steady. Right. If we look at the TRAB kinetics of treatment, right, medications bring down the proportion of TRAB levels quite well, followed by surgery, and then in radioiodine takes a longer time. And in fact, in the first several months, there is a paradoxical rise in the TRAB following radioiodine therapy. Right. So this is the another study showing the rapid decline with surgery, right, versus the increase in TRAB with radioiodine and the slower decline with radioiodine. And the probability of persistent the high TBII is much lower with surgery versus radioiodine. So the TRAB has influenced the choice of treatment modality, right? Many have been interested in this question of, can we not use the TRAB to predict who is going to relapse in Graves' disease? And this is a meta-analysis in 2017. It shows that the TRABs represent a significant marker for relative risk of relapse, right? At about 0.3. And then if we look at 5 different TSH receptor antibodies, right, all assays are capable of predicting, the relapse of Graves' disease. Right, and there's also been a trend to try and improve the predictive score by coming out with something called the GRADE score, right? So age, all right, less than 40, you give 1 point. Free T4 more than 40, another point. TBII more than 22 points, and goiter size another 2 points. So the maximum score is 6. And if you have a class 3 grade score, the risk of recurrence is close to 70%. And so here is the in figures the recurrence rate, right, over time by the different classes of grade score. So this has also been validated in a larger data set of 740 patients. Again, the same. This is the Kaplan-Meier curve of relapses. All right. So the the lower your grade score class, right, the probability of remission is much higher. Then we have outcomes of Graves' disease with anti-thyroid drugs and the time course of the TSH receptor antibodies, right? If the initial levels, the likelihood of becoming euthyroid at 51 months was, much lower. Those that have higher median TRAB levels took longer time for remission. And those who could not attain targets with very high initial levels are more likely for flare-ups, and serial TRAB levels are much more informative. And so, again, the higher the TRAB level at diagnosis, the less likely to achieve remission. And another group in Denmark, right, 2 centers over 200 patients, again showing that TRAP negative with normal TSH for 2 months with 5 milligrams of methimazole, right, would be the control group. So the predictors for lack of remission would be TRAP levels more than 5. And this is an odds ratio of 3.4. So the utility of TRAB for Graves' disease would be, well, at presentation, right, the risk of relapse is 50 to 2/3, right, for all patients. But if the TRAP is more than 12, right, the relapse rate is 60% at 2 years and 84% at 4 years. So one could say that perhaps you might want to discuss radioiodine therapy, right, in some time. Now, if the TRAB is more than 7.5 after 12 months or after 18 months, and when the antithyroid drugs are stopped and the TRAB is still more than 3.8, then they have a high likelihood of relapse. So either we continue giving antithyroid drugs or to consider other treatment modalities. So this is how one group in the UK is using this information of TRAB. Right. Given the fact that we talked about stimulating, blocking, as well as total TRABs, should we subtype? For diagnosis, the difference is less important. And, both the TSI and TBI will decrease with initiation of antithyroid drugs, right? Of course, respondents more than the non-responders. TSI measured by bioassay is technically challenging, and the automated platforms like Emulite will be preferred. However, there's no great difference between the TSI and the TBI currently. But the subtyping may have value in complicated situations such as prediction of neonatal thyroid dysfunction or an unusual Graves' disease with severe eye disease, or when patients may not be responding and one wonders whether there is a change in the type of TRABs, right? Whether it's TSH binding inhibition versus stimulation. So in summary, assays now can assess TSH binding inhibition as well as thyroid stimulating IgGs. The newer third generation assays now have superior performance. And we have got specific TSI assays, but it's used in reserve for the more difficult cases. Some variation exists between the assays, and more standardization and harmonization would be helpful. TRAP can be used to predict remission and relapse. TRAP levels persist longer after radioiodine than after surgery. It can also be used to predict the risk of eye disease. And high maternal TRAB increases the risk of neonatal thyrotoxicosis. And in some cases, the blocking antibodies may also be involved in congenital hypothyroidism. And a few years ago, I wrote an editorial saying, "Is it ready for prime time?" I think the answer is a definite yes. Okay, thank you very much. Final slide. In this season of SARS-CoV-2, one wonders if diabetes is a risk factor what about thyroid disease? So far, other than a few case reports of subacute thyroiditis occurring, the presence or absence of thyroid dysfunction and its treatment has not been found to influence SARS-CoV-2 prognosis or course of disease. So we would need to watch this space further. And with that, I thank you very much.
Thank you, Dr. Ah, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Dr. Maria Bandari, PhD, PMP, Manager Scientific Affairs at Abbott, will address questions due to time zone differences in Singapore. We will ensure that we provide you an answer to all the questions posed, and we will forward unanswered questions to Professor Ah for his insights and follow up with response via email. Let's get started. Our first question is, what is the difference between TSAB and TSI?
Hi, thank you so much. I'm Maria. Hopefully you can hear me
Yes.
okay.
Yes.
Good. Okay. Thank you so much, for the question and everyone attending this webinar. Just very quickly and something before we start with the question, just want to make sure that everyone is aware that this webinar, as we have in the screen, it's intended as a scientific educational session to inform laboratorians as well as healthcare professionals, as you saw with all the latest research and published data. So the views and uses demonstrated in this presentation may not necessarily reflect the current regulatory approved intended uses or claim. To just make sure that you check with your with your respective areas. And as you know, this was supported by Abbott. Now, in regards to the question, so TSABs or TSI or TSAB, they're essentially the same thing. One is called the thyroid-stimulating antibody, that would be the TSAB, while the other one is called the thyroid-stimulating immunoglobulin, and that's the TSI. However, the preferred nomenclature is really to use now the TSH receptor antibodies, or what we call TRAB. And like Dr. Aw mentioned, which is good to remember, most of these TRABs are stimulating, although occasionally there's some blocking TRABs, as he mentioned as well. And in those cases, rather than stimulating, they can cause, instead of causing hypothyroidism, they will cause, instead of hyperthyroidism, depending on whether they're stimulating or blocking.
All right. Next question. What does a high TRAB baseline in patients indicate, and how does this relate to their remission and treatment?
Sure. So I think this was kind of towards the end of the presentation. And remember, Dr. Aw went through all the different uses for TRAB, whether it's diagnosis or treatment. And actually, he made an important point about this to say that he thinks that TRAB, it's one of the most important uses is during this treatment. So a high baseline of TRAB, it's confirming that this patient, first of all, has grave hyperthyroidism. And it indicates also that this patient is very likely to relapse at the end of the 18 months of medical treatment with the anti-thyroid drugs. So this patient, it would be really important to have the TRAB measured throughout, and actually before deciding if they're going to discontinue their medication or not. If TRABs are not normal, then most endocrinologists would most likely continue the anti-thyroid drugs further for, let's say, another 3 to 9 months, and then they would repeat TRAB again. However, the TRAB could also help indicate if it's low, then it could also indicate that this likelihood of relapse would also be low. So there's a good correlation when it's done at the diagnosis time.
Okay, thank you. Next question. What leads to variation or variations in T3 and TSH when patients are unwell, and what implications does this have for their diagnosis?
Sure. Yeah, so one of the things to remember, again, this was very early on that Dr. Aw mentioned that most of the T3, it's not synthesized in the thyroid, but it actually comes from the further metabolism from T3 to T4, and this mainly occurs in the liver. Now, when patients are ill from any reason, the body tries to conserve the T3, and it shifts the metabolism to an inactive product, which is called reverse T3, and thus this results in low T3. TSH, on the other hand, it's low, normal to slightly elevated, and T4, which normally is free T4, it's often elevated. And so this phenomenon of low T3 with normal TSH is what we call euthyroid hyperthyroxinaemia, or other words, is non-thyroid illness, which is also known by the letters NTI. And so the implications for thyroid tests in this case is that they really shouldn't be ordered unless it's absolutely essential. And just repeat them once the patient condition is more normal, because it may be related to some other illness and not really due to a thyroid condition. And most endocrinologists know this, but you know, it's something that the generalist needs to be also cognizant for.
All right. Well, it looks like we have time for one more question. Thank you for presenting the published data. Can you elaborate on the scientific data and literature related to Abbott's TRAB?
Sure. So Abbott TRAB assay is commercially available now in some markets. However, make sure to check with your local representative for the availability, as you know, it's still being rolled out and approved in different areas. The assay is a chemiluminescent microparticle immunoassay. It is used for the quantitative determination of the thyroid-stimulating hormone receptor antibodies, so TRAB, in human serum, and it will be used also as an aid in the differential diagnosis of Graves' disease. Just like a lot of the assays that Dr. Aw talked about, it is a third-generation assay. And it is an automated delay one step. And so without the need of any pretreatment, the samples can just be directly incubated, and then the trap present in the sample will compete with the TSH receptor antibody. So just like the other competitive assays. The Abbott assay is standardized also against the WHO second standard. And in comparison to the other assays, it also has a very good precision. It has a reportable interval that goes from 0.7 to 500 units per liter, with also, you know, LOB, DQ, other comparables as well. The diagnostic cutoff have been established to be about 3.1. But the important thing is that just like some of the data discussed here, this cutoffs are being evaluated also for with specimens from individuals with medical conditions that are unrelated to Graves' disease, and the results continue to show great specificity with that cutoff for the Abbott assay. And lastly, it has a good correlation and low bias against the Roche method. And even though they have different diagnostic cutoffs, we have that same concordance as shown with some of the other publications, and there's a greater than 98% positive and negative agreement within the assays. So that's kind of. I think we're at top of the hour. Yeah.
Well, thank you. Thank you again, Dr. Aw, for your time today and your important research. And thank you, Dr. Bhandari, for answering today's questions. We would also like to thank LabRoots and our sponsor Abbott for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.